Hello and welcome everyone to Oral Pathology 360's Tuesday program, OP Tuesdays. Today we are having another session on the dentistry special. Dentistry special is where we bring content that basically is relevant to all of us, dentists and all of us, to anyone who's a dental surgeon. So today's topic is about dementia and Alzheimer's. This is a very important topic, and a lot of people in the world are suffering from this. When you think about it, that one person is developing dementia every 3 seconds. That's a monumental number. And although India and maybe a lot of the world besides us are fairly young, maybe with the exception of possibly Europe, but the thing is that the numbers are increasing everywhere, and now it is not really limited just to the elderly. So it is very important to be able to understand and recognize the signs early, even in our practice or everyday practice. So today I have brought you a lecture that's recorded from the time when we had a masterclass, a webinar that was for the World Oral Health Series, which was not to leave anyone behind. And basically, this was a part of that team. So it was uh, dementia sensitive dental care. And we had a whole series, but today I'm bringing you one part that was by Dr. Merchant. Dr. Merchant is working in a number of different hospitals. He's a psychiatrist and he is very well known, and he is also, I would say, one of the kindest and the most mild people I've met. He is exceptionally good at his work, and today you will realize that in his lecture that he is really very caring, and he also has a very good understanding of this, because I guess because of his very caring nature, he has a lot of patients who require this care. Of course, it's a recorded lecture, so obviously he's not with us. But anyway, I would really like to hear your discussion and your comments at the end. So let's just watch this and come back. As usual, please increase the resolution or the quality if you're watching on phone, so that you'll be able to see the slides well. And also wait on with us till the end, because there's a lot of news.
It is amazing that a group of dental surgeons are wanting to know more about dementia. It is, I think, one of the most neglected subjects in medical fraternity. And as Dr. Mandana has already mentioned, that a lot of medical professionals are also not aware of what exactly dementia is. And this is where you realize when a lot of them come with their loved ones suffering from cognitive problems. That is the time we realize that they are so unaware of what this illness is all about. And as we will go through the presentation, we will know that the magnitude of the problem is enormous. I'll just start sharing. I'll just take support of a few slides, and then I'll just speak what I would want to. I'll just share the screen. As you can see here, the magnitude of the problem is enormous. It is said that around 24 million odd people have dementia, and approximately 4.3 million new cases of dementia are diagnosed every year. And if somebody is very good at maths, they can do their calculations. I'm very bad. This somebody has done it for me. It comes down to almost one new case every 7 seconds. So the number of people affected will double every 20 years. So it is said that by 2040, there will be 81 million people who will be suffering from dementia. Hopefully by then, we should have some cure for dementia, which we still don't have. But I'm sure by 2040, at least we will have something, so that these numbers would be much lesser than what they have been predicted so far. So the magnitude of the problem is enormous. Every day we see in our practice that elderly people are brought to us and they're first time diagnosed as having dementia. They come in with various cognitive, behavioral problems, etc., and they are diagnosed with dementia. So basically what I have seen in my practice is that when we mention the word dementia, it is usually a idea that people have that it is basically a illness where only memory is affected. But that is not the case actually. Actually, if you see in dementia, it is not just the memory that is affected. Of course, there has to be to diagnose dementia, there has to be demonstrable impairment of memory, but it is much more than that. So the actual definition of dementia says that, of course, there is amnesia, there is memory, language is affected to a large extent, so there is aphasia that develops with dementia. The third A that is affected is apraxia, the ability to do fine things with their hands, the ability to execute certain things like opening of locks, buttoning their shirt. All these things get affected. And the fourth domain, which is of course interest to me and which is the most problematic area, is psychological symptoms or behavioral problems, behavioral and psychological symptoms that accompany dementia. So there are four domains that are largely affected. One is memory, one is language, one is apraxia happens, so ability to do things gets affected, and the fourth domain is behavioral and psychological symptoms that occur with dementia. So basically, there has to be a decline from the previous level of functioning. As I mentioned, there has to be a demonstrable impairment of memory. The other areas are language, judgment, basically frontal lobe functioning gets affected, construction and visuospatial functioning gets affected, abstraction and personality. So one of the first changes that happen in dementia is change in personality, and we will see when this happens and how this happens. So these impairments have to be of a magnitude where they interfere with functioning of daily activities. The activities of daily living, they need to be affected. Only then we can diagnose it as dementia. And why this is so important, I will mention in the next slide. Usually the onset is insidious. It occurs over a period of around 6 months or so. So is dementia a unitary diagnosis? Is it a single diagnosis? No, it is not a single diagnosis. Dementia can be caused by various underlying disease processes. Of course, the largest number of patients who are suffering from dementia are of the Alzheimer's type. So there are 65% of patients who have dementia are suffering from Alzheimer's type of dementia. There are 5% who are suffering from vascular dementias. So post-stroke, multi-infarct dementias, those are the vascular dementias. Those are around 5% of the patients. A lot of patients will have overlapping kinds of dementia where they would have vascular dementia and Alzheimer's dementia. So there would be around 10% of patients who would have a mixed picture of vascular dementia and Alzheimer's dementia. Why is it important to know which type of dementia the person is suffering from? Is very important because the prognosis, the progress of the disease varies when we know the underlying cause of the dementia. Also, the line of treatment also varies, which I will touch very, very briefly as we speak ahead. Then there is around 5% of the patients who will have Alzheimer's dementia and Lewy body dementias. Around 7% will have Lewy body dementias, Parkinson's disease, diffuse Lewy body disease. Basically, this Lewy body dementia is very, very important because one needs to realize that it is a lot of motor symptoms will also be affected. So there will be a lot of stiffness, bradykinesia, slowness of activity, short shuffling gait. So basically, a lot of symptoms of Parkinson's disease will be there in Lewy body dementias. Then around 8% would be various other kinds of dementias, would be frontal lobe dementia, Creutzfeldt-Jakob disease, which is a slow virus disease, progressive supranuclear palsy. So basically, in a screenshot, we can see what are the types of dementias and how its prevalence is, in various forms. So we will go into details of the why we need to do that, know which kind of dementia it is a little later. So a lot of people come and complain to us since a little bit of awareness is going higher, and people who have members in their family who are suffering from dementia sometimes come and self-diagnose themselves that do they have dementia. They have a lot of doubts whether they have dementia. So with normal aging also there is a cognitive decline that happens. So what is that cognitive decline that happens? There is sometimes trouble concentrating in presence of distractions. There is decreased ability to attend to multiple channels, difficulty multitasking, difficulty recalling names of acquaintances. Sometimes spatial memory is affected. There is slowing of reaction time. There is delayed verbal memory, and it becomes mildly decreased. So these are sometimes that we see, that with aging, these are normal cognitive problems that we see, but the activities of daily living are not affected. So there is an entity called as mild cognitive impairment, where a person may have some symptoms, like may have some problems, remembering things, some problems where they have difficulty in multitasking, recalling names, some spatial memory, but it is not deteriorated to a level where their activities of daily living is affected. So when their activities of daily living is not affected and there are some symptoms that are present, we usually call it mild cognitive impairment, and we usually keep a close watch on these patients. Till now, there has not been enough research that if you start medicating patients with mild cognitive impairment, will it prevent them from developing dementia or no? That is still not very clear. A lot of people say that you need to treat them at that stage so that they may not progress to dementia, or the progress may happen, but it may be delayed significantly. But there is still not very, very clear guidelines. But generally, we need to follow up on these patients very, very closely. So these are some of the images of the PET images and MRI images of patients suffering from dementia. Here we can see that in dementia, the MRI shows significant atrophy seen in patients suffering from dementia. So basically, as we have said, that dementia is not just memory impairment. What are the areas that it affects in a person suffering from dementia? So what are the ABCs of dementia? So activities of daily living is affected. Cooking, grooming, dialing a phone, etc., becomes very, very difficult for patients with dementia, and they need sometimes assistance in activities, in executing activities of daily living. Their behavior, this is a very, very important part. Behavioral changes in patients suffering from dementia is very, very common, especially in the moderate severity or the severe category of dementia. Usually, this is what is sometimes the presenting complaint: depression, aggression, apathy, hallucinations, delusions, psychotic behavior. That is very, very commonly seen in patients with dementia. And this is one of the most common complaints for which the caregivers approach doctors. They say that we can understand that the patient is unable to remember things, but we cannot tolerate or cannot manage the behavioral changes that has been happening. And of course, the cognitive changes do happen in dementia: loss of memory, like remembering names of people, fumbling with words, etc. The cognitive decline that happens, the memory impairment that happens, is a very peculiar kind of memory impairment that happens in dementia. Usually, it is the recent memory that gets affected first. So the person may not be able to remember what he had for lunch or what he had for breakfast, but remote memories, very, very old memories, remain intact. So the person may be able to tell you, that what has happened 20 years back, what had happened 15 years back on the trip that he went with you on that trip. So basically, it starts with recent memory impairment, and this causes a lot of confusion in the family members. They come and tell us, oh, the person can remember everything, old things that has happened, but when you ask them about recent memory, they would forget things. They would forget if they've had, when have they had their last meal, whether they have had a meal or not. So they would repeatedly ask, for food again and again. They would forget if they've had medicines or not. So it is a recent memory which gets affected in dementia first. So what are the first changes of daily activities that family members notice in people suffering from dementia? They keep complaining that the person has been asking and saying the same things over and over again. So sometimes they come and tell us that, doctor, we are fed up, that my father or mother keeps asking the same thing. I've told her that tomorrow we have to go to meet somebody, and they'll keep asking me, when are we going? When are we going? When are we going? And they keep doing that. Even when I keep answering the person, they just keep forgetting it. Sometimes this becomes very, very tricky. They've kept things somewhere, and when they cannot find it, they feel that somebody has stolen their things. So they accuse people, family members, servants, caregivers, of stealing their things. And this becomes sometimes a very, very, very sensitive issue in families, especially if the mother-in-law is accusing the daughter-in-law of stealing piece of jewelry or money. It becomes a very, very sensitive issue in the house. Untidiness is another thing that is noticed by the caregivers. Sometimes they forget, they miss getting down at their usual station. Sometimes they get lost at times, so many a times they would just go down to buy something and forget in which lane they have their house, and sometimes get lost in the neighboring locality. Sometimes their sleep cycle gets affected very early in dementia. When they get up in the night and move around in the house, they forget where they've kept their objects. Miscalculating money handling for them becomes very, very difficult, even in the initial stages of dementia. How much money to give, how much to take back from the grocer or the or wherever, small stores that they do their purchasing from. They cannot recall things, and sometimes they become very, very irritable. So these are early changes in dementia. Also, these are the changes that are noticed by the caregivers very, very often. So basically, this is one of the most important things that caregivers complain about: the behavioral and psychological symptoms of dementia, which is called as BPSD. And sometimes this is the presenting complaint with which the person is brought to a psychiatrist, a neurologist, a physician. So there are core symptoms of, as we've already discussed, memory impairment, judgment impairment, problem solving impairment, executive dysfunction. As we said, apraxia, agnosia, aphasia is there. But then the things that are happening, what I was written in the red, is the most distressing for the caregivers. Delirium is very, very, very commonly seen in patients who are suffering from dementia. So it would be a delirium added on to dementia. And when they are delirious, they are disoriented, they are hallucinating, they are very, very disruptive, they are not cooperative, the sleep has gone for a toss. There are a lot of behavioral problems which the caregivers find it very, very difficult to handle. Sometimes a simple thing like a urinary tract infection in a patient suffering from dementia would cause a delirium to happen. Anxiety is again very commonly seen in patients suffering from dementia. Agitation, depression. Depression is again very commonly seen in dementia. In fact, there is a terminology called as pseudo dementia. This is in patients who are suffering from depression. Their symptoms look very similar to dementia, but they are actually not suffering from dementia. When you treat the depression, the cognitive symptoms improve, and you realize that it was not actually dementia that they were suffering from, they were suffering from depression. So sometimes the overlap is so much that it is difficult to tease out both of these disorders. Hypochondriasis that happens with them. There is violence sometimes happens with and foul language. There are mischievous acts that sometimes very silly acts that patients with dementia do, wandering away. Filthy acts, lot of times that family members come to us in distress that, the elderly gentleman or the elderly lady is acting in a disinhibited manner. Lot of times family members bring their elderly people that, he's inappropriately touching another family member, or she's inappropriately touching herself, and things like that. And they wonder that at that age, how can somebody do that? Actually, it is not their character, it is their disease which is causing this disinhibition. This is what we need to educate family members. There have been cases where daughter-in-laws have come and said that the father-in-law has touched me inappropriately, and this is after 15 years of marriage that this has happened, or the wife brings the husband that he's trying to inappropriately touch the housemaid, and things like that, and he was never like this. So it is actually the character of the person. The disease causes this inhibition. There is resistance to care, there's overeating, over dependence, sometimes talkativeness. Sleep disruptions is very, very, very common in dementia. In fact, there is something called as a sundowning effect. In later stages of dementia, what happens is that patients suffering from dementia basically start showing behavioral problems more in the night. As the sun goes down, as it becomes dark, the patient starts showing behavioral problems. So the family members usually say that, I don't know why, but he's the most disruptive during the night. He's quite manageable in the day. Psychotic symptoms also occur in dementia, that is hallucinations, delusions, irrelevant talk. Hallucinations are very, very commonly seen in patients with dementia. Delusions are very common, and delusions may be paranoid or persecutory delusions that we see in patients with dementia. In fact, it is behavioral problems are presented in 51% of the patients as the presenting symptoms. As I said, sometimes patients bring them in with behavioral problems. So actually, this is a very interesting slide so dementia doesn't start all of a sudden. A person doesn't sleep on Saturday night and gets up on a Sunday and has symptoms of dementia. It starts quite a long while ago. So what are the symptoms that are seen, in early stages of dementia, months before the diagnosis happens? So that is on the left-hand side. We see that, there are personality changes. Personality changes are one of the first symptoms that you see in persons suffering from dementia. And it could be, maybe around 40 months before the onset or the diagnosis of dementia. So there would be social withdrawal, there will be depression, sometimes there would be paranoia, sometimes the depression would lead to have suicidal ideations, there would be anxiety, there would be change in their rhythm of their diurnal rhythm, basically sleeping and waking up cycle. So anybody above 65 years of age who presents to us with depression, anxiety, behavioral problems, and things like that, we need to rule out dementia in them, because these might be the presenting complaints now, and gradually we would see the cognitive decline later on. Then, at the time of diagnosis, usually they come with mood changes, accusatory behavior, irritability. As it progresses further, then we see, delusions, sexually inappropriate behavior, socially unacceptable behaviors, wandering, agitation, aggression. These are the behaviors that we later on see, after the diagnosis. But we need to check and be aware that sometimes personality changes, anxiety, depression in an elderly person might be later on that they will develop, symptoms of dementia. So I will not go into etiology of these things. Basically, in stages of dementia, mild, and especially in Alzheimer's, I'm talking about Alzheimer's more because it is one of the most commonly seen type of dementia that is there. Usually, as we see, the most problematic symptoms are apathy, agitation, depression, and anxiety. And as it progresses from mild to moderate to severe, the frequency of this increases. More and more number of patients start showing these symptoms, and the intensity of these symptoms also increase. I will just digress from here. I forgot to mention, why we need to know the type of dementia that the person is suffering from is important to know, because the way the disease progresses in each one of them differs, and the line of treatment also differs. So how it progresses is that in vascular dementia, usually it's a stepwise deterioration. So the person will deteriorate, he will be there and for some time, and then he will go down another step further. So it is a stepwise deterioration in vascular dementias. In Alzheimer's, it's usually a smooth curve kind of a thing going down. Basically the deterioration happens gradually, but there is no stepwise deterioration. In patients with Lewy body dementia, we need to see a lot of Parkinson's symptoms might be there in these patients with Lewy body dementias. And mind you, we need to be very, very careful in patients with Lewy body dementias when we are prescribing psychotropic medications, for their behavioral control. That might worsen them dramatically. They would become stiff, rigid, akinetic, bedridden. So one needs to be very cautious while giving psychotropic medications to patients with Lewy body dementia. And then basically the frontal lobe dementias. In the frontal lobe dementias, usually the presenting symptoms are behavioral problems, disinhibition. Those are the presenting complaints. And then one would see the cognitive complaints coming later. So this is the way the disease progresses in the various kinds of dementia that we spoke about. Okay. So again, these are the symptoms, there are some more organic, some more functional, wandering behavior, irritability, more towards the organic side, more towards the functional side, depression, delusions, hallucinations, those are there. So behavioral symptoms are usually evaluated by observation. Psychological symptoms are evaluated by interviewing the patient. So what do we do, with these patients? So I will first talk about management of behavioral and psychological symptoms, and then go on to talking about management of cognitive symptoms. Because as I told you, the caregivers are more concerned with the behavioral and psychological symptoms of dementia rather than the cognitive symptoms, and they are the most distressing for the patient and for the caregivers. So basically, one needs to understand that there are patient factors that need to be considered while treating behavioral and psychological symptoms. There are caregiver factors and environmental factors. So all these things, the premorbid personality of the person, the caregiver's level of caregiver stress, the environmental factors one needs to consider. Usually what we are seeing here is that when there are unmet needs like hunger, thirst, pain, there are acute medical problems, sensory deficits, then there is more of a behavioral problem that we see in patients with dementia. When there is caregiver burden, stress, lack of education about dementia, there are communication issues, and there is a mismatch of expectations and dementia severity, then it causes again to lead to behavioral problems, but the contributing factor is the caregiver more than the patient. Sometimes the environment is overstimulating, understimulating, there's a lack of activity, lack of established routine, which causes these behavioral and psychological symptoms. It is important to identify these because to treat behavioral and psychological symptoms, one needs to first try out non-medication approaches, and only as a last resort use medications. The medications used are basically psychotropic medications. There will be antipsychotics, antidepressants that would be used. But remember that these medications have major side effects in patients with suffering from dementia. So they need to be used cautiously, judiciously, and as a last resort. In fact, the FDA has a warning for use of antipsychotics in patients of dementia, as it increases the risks of cerebrovascular accidents significantly in patients with dementia. So medications need to be used as a last resort for management of behavioral and psychological symptoms in dementia. Non-medical approaches need to be used first, and that is why we need to try to identify what is contributing to causing or exacerbating the behavioral and psychological symptoms. So what are the non-pharmacological treatments? Activity and recreation, aromatherapy, family tape recordings, sound, music, one-to-one interaction, physical activities. There are a lot of techniques that one can use non-pharmacologically. Very, very simple things like making a chart of, their activities of daily living, and telling the person himself to map the chart. If he's had he's had his breakfast, then to tick in the column where they've had their breakfast, so that they don't go and repeatedly ask. And even if they ask, they can just be shown the chart that you've already had your breakfast here, you've signed it here, you've marked it here. It reduces the friction between the caregiver and the patient. A lot of such techniques can be applied to persons with dementia. What are the medications that we use to to manage dementia. Basically, there is no cure for dementia as of now. There are medications that are available, two group of medications that are available to, to slow down the decline of dementia in patients so that the decline happens slowly. The rate of progress at which it is deteriorating can be slowed down. So what are these two groups of medications? They are cholinesterase inhibitors and NMDA receptor antagonists. So memantine is one of the NMDA receptor antagonists which is available in India, can be used. Donepezil is a cholinesterase inhibitor. Rivastigmine and galantamine are three cholinesterase inhibitors that are available in India. They can be used to slow down the cognitive decline in these patients, but they cannot, there is no medication to reverse the cognitive decline in these patients. Of course, there was a very promising drug which was just launched in United States, and I hope I am pronouncing it properly, aducanumab. It has bombed. Basically, it has shown that it is not effective in reversing the beta amyloid plaques that happen in the brain. In fact, there's a whole controversy of how did they get an FDA approval. It's a monoclonal antibody costing around $55,000 a year, but unfortunately, it has shown to be not effective and have significant side effects. So as of now, we don't have any medications to reverse the cognitive decline. We just have medications to slow down the progress of the disease process. Antipsychotics can be used for behavioral symptoms, antidepressants, anticonvulsants, and anxiolytics. But as I have already mentioned, these are not free of controversy and not free of side effects. They should be used as a last resort. Sometimes we use a combination therapy of an NMDA receptor antagonist and a cholinesterase inhibitor, and it is shown that it is beneficial in reducing or slowing down the cognitive decline. Thank you very much. Yeah. I totally agree with you. In fact, recently I was reading certain studies that all throughout my medical education and practice, I was taught and used to read that, benzodiazepines would cause cognitive decline. Very surprisingly, it has been shown that the benzodiazepine does not cause cognitive decline, whereas untreated anxiety causes more cognitive decline. So now they're saying that even if you have to give benzodiazepines, you treat anxiety and you will save the person from going into cognitive decline. And we were always, you live with the anxiety, but not with the benzodiazepine. We were pushing people into more cognitive decline. So it's a complete different way of thinking and looking at dementia these days. Can we predict the cognitive decline in advance? Yeah, there are early signs, as one of the slides that I had presented, that sometimes people do show early signs which are quite a few times neglected and not picked up. And when retrospectively you speak to the relatives, they'll say, yes, the onset has been since quite some time. The entity that we spoke about, mild cognitive impairment, okay, where there is some cognitive impairment, but the activities of daily living are intact. That is the time that one needs to watch these people very, very carefully, that if they are going into early dementia or something like that. So those kinds of changes, if there are personality changes, if there is anxiety, depression that comes up, even when the cognitive decline is not there, one needs to check for cognitive decline, see, longitudinally if they are setting in. So any personality change, any change in their functioning, cognitive functioning after the age of 65, one needs to watch them very, very carefully. And if dementia sets in, then early interventions would be helpful. So generally, when there are symptoms of cognitive decline, or when we suspect that there is a cognitive decline, even if the patient is presenting with anxiety, depression, we ask for an MRI. But routinely in the general population, we do not screen people for dementia with an MRI because it's more of a clinical diagnosis rather than a diagnosis that can be done on MRI. Sometimes it can be very, very, very difficult. At times you would see significant atrophy in the MRI, but the functioning of the patient would be much better than what you would see, in a person with little atrophy of the MRI, but the functioning could be very, very bad because there are multiple other factors involved. So the predictive value of an MRI is very low. Generally, when a person comes with cognitive decline, we do look for reversible causes. And in that screening test, we do ask for an MRI as a routine thing when we come across patients with cognitive decline. So we do screen people, for reversible causes like a thyroid, like a B12 deficiency, like a vitamin D deficiency, just to check if there is a space occupying lesion in the brain, or whether it is a vascular thing, or where the cognitive, where the atrophy is, which region of the brain the atrophy is, and those kinds of things. But generally, screening the general population with MRIs is not recommended. It is not recommended. One, it is accessibility to the entire population is low, affordability, and it doesn't give a proper yield. So even if you would screen all patients for reversible causes, you might find some reversible causes only 2 to 5% of the patients. That is what the statistic says. So you may do very, very expensive tests, but you may not come, there may be no yield to those tests. Only 2 to 5% of the patients we would find a reversible cause. Yes, if it's a very early onset of cognitive decline, if it's a very rapid onset of cognitive decline, or there is an atypical feature, then we would like to see something like an autoimmune encephalitis. Those tests are expensive, and we would like to run those panels. We would like to see, if there is any heavy metal toxicity, all those kinds of things, but not routinely doing an MRI. In fact, now the PET scans have more utility than MRIs, and which are not very, very, it's not extremely expensive as compared to MRIs these days. Okay. So one is that when the person comes with cognitive decline, so first of all, establishing a diagnosis is important. Okay. So we generally run routine tests just to see if there is a reversible cause. We check if there is another psychiatric problem which is causing this kind of a cognitive decline, whether there is coexisting anxiety, coexisting depression, there is substance abuse, or there are some medications which are causing this kind of a cognitive decline. A lot of times these patients are on very high doses of anticholinergic medications, which are absolutely contraindicated in these elderly patients, and that would be causing a cognitive decline. So we look at causes which could be contributing to the cognitive decline. If we find them, we try to eliminate them or address them. If we are not able to find them, and we suspect that it is dementia, then we go ahead and get a neuropsychological assessment done, neuropsych testing done. There are certain neuropsych tests that are done specially by psychologists. Quite a few of them are available in Mumbai now, trained. I know other cities may not have people who have been trained in neuropsych testing, but generally in a psychiatrist or neurologist's office also, there are certain screening tools like MOCA. It's a cognitive assessment test that is done, a mini mental state examination. That would give us, a memory test that is there. So these are screening tools which generally we or our assistants administer on patients to know the degree of cognitive impairment. And serially, sometimes we repeat these tests on follow-up just to see how the patient has been progressing. So this is generally overview of the protocol that we follow when a person comes with kind of cognitive impairment. Yeah, I think they should. They're so preoccupied with getting the patient to sleep at night, the behavioral problems, the relatives hounding you, that the patient is not allowing them to rest, that the teeth come as a last priority on your list. But I agree with you. One should be, this should be an instruction at least given to the relatives to have their dental checkups done regularly. I agree with you. But generally, it's missed. I'm also, I've never advised anybody to go to a dentist, although I see so many patients with dementia because they're so preoccupied with the delusions, the hallucinations, the cognitive problems, the daily care that you need to provide to them, that usually gets neglected. But we need to pay a little more attention to that. Okay. No, I think awareness about diagnosing, managing dementia is extremely important. And, over these 22 years that I've been practicing, we're seeing more and more people with cognitive impairment. Although, as doctor said, that India is a young country, but we have a significant population, elderly population, and as the joint family system has collapsed in urban India, more and more of these elderly patients are living on their own, which is becoming even more difficult for them. My grandmother would have developed dementia, but she had 3 daughter-in-laws to take care of her. When I developed dementia, I don't know, I wouldn't have anybody to take care of me. So early diagnosis, interventions, early proper management can go a long way to help our senior citizens when they develop this kind of a disorder, until we have drugs to actually reverse the condition.
Right. That was indeed a very, very interesting and very thorough presentation. It was from our recordings, and you might wonder why exactly did we need to see that. Now, the thing is that very often, as dentists, first and foremost, is that people who come to us regularly, we might be the first ones to be able to catch a difference in someone. in someone's behavior, in someone's level of understanding, in the way they deal with things, and we might actually be early to catch it. Also, is the fact that with the numbers rising, I think every healthcare worker should be able to recognize it, because we might see it not just in our own family, but also in people we work with. I did see it in my own mom, and at that moment, I was completely unaware, which probably was the reason it was caught so late. By the time I suddenly felt that no, this is wrong, it was quite late. It was quite a long time. So it is essential that we actually catch up with this, because the changes are very minor to begin with. And it's like, someone who's retired, like happened with my mom. So she was retired and then said, okay, I don't really want to do the work. And she had been a dress designer, and had a institute for years together. That was her passion. But even then, since she was retired, the day when she said, I don't really enjoy doing this, I'm not really want to do this much more, we didn't think much of it. After all, it's retirement, right? But in fact, it doesn't really work like that. Sudden changes we need to be aware of. As dentists, we also need to be aware, because it could actually be dangerous. It could be with the medications we give, it could be with the fact that these patients at times, like it was mentioned, may have suicidal tendencies. And if you're completely unaware, a number of instruments in the dental clinic can be quite dangerous. So if you're completely unaware, it could become a problem. And of course, things like oral health, and maintenance of dentures, appliances, these become really essential to keep checking, because now suddenly you have a patient who no longer is likely to be able to tell you why I have a pain in my mouth. They might not even be able to tell you that there is pain. They'll be uncomfortable, but they won't know why. So these are all important, and I know it seems like a little offbeat topic, but then we do cover the offbeat topics here, and let's say this was one more of them. And coming to what all I have to share with you, let me bring back what I just hid. Right. So the first thing is that we have this, the registration is open for the second live event in the open mic series. And that live event, the live event itself is going to be on the 12th of March, but the last date for submitting your abstracts will be on the 11th of Feb. So do make an effort if you would really like to take part. The prize is becoming one of the invited guest speakers among the panel of experts that will be there as guest speakers for the International Oral Diseases Case Presentation Conference. If you remember, this was an event we had. We didn't have it on last May, but because of well, my health problems, but we're having it this year, and it is a combination of everything. If you have missed the last one, we reached over 50 countries. We had numerous institutions that were involved, and this one is also going to be, I would hope, better. But there will be guest lectures, case presentations, both as oral and poster presentations. So, in fact, start looking for your cases if you would like to present something. And there's a lot of networking, group meetings, one on one video meetings, and a large number of academic institutions involved. So it's an all in all interesting and a definite should not miss event. Do save the dates, and for both the open mic and for this, if you just go to our website, that is oralpathology360.com, you will find the details and the links right on the homepage. You just have to scroll down and then click on the appropriate picture. And for the conference, of course, right now we only have a link so that you can register your interest. So we can share with you as the dates and things keep coming in. But the date is, of course, fixed, and within the next week, we will share the remaining of the data. So, with that, right, let me just thank everyone who is here. Mr. Madan Reja, I do hope you're well, and thank you for joining us again today. I don't know who else is there since you have not signed up your name, but let's move on to. Oh, yes, and I am also, this is the point where I thank our new members. These are people who have joined membership on the YouTube channel. If you look right now below the channel, below the video, you will be able to see a
join button. From there, you will see, if you click on that, there are three different categories you can join, three different levels of membership, and each has its own little perks. And on top of that, you will also be helping us, supporting us in bringing you more and more content, including and mainly the atlas, the video atlas of the clinico-pathological video atlas of oral and maxillofacial diseases. Oh my, that's a mouthful, but okay. So you got it. And yes, and we will thank the new members every time. There's a lot that is there. Please go and check it. And right, so we have our new members also done. Right, now I got to tell you what's coming next week. Coming Tuesday, we have with us Dr. Eleni, and I'm sorry, I still can't pronounce her surname. I have to ask her, but so she's going to be talking to us about AI. She's going to be talking about simplifying AI in oral cancer detection and prognosis. So she's an oral medicine specialist, and she's going to be talking on the topic with an update and her own experiences. She's been working on this for quite some time, so she wants to basically share everything she has found with everyone, so others who are entering the field now can do so a little ahead of the curve. I do hope you will remember. This is already posted. It's already there on YouTube. So if you just look around, open the channel, and you can even put a notification right now. Yes, and that's about it. And right, we don't have much more to do. Thank you everyone for being here, and see you on Tuesday. Have a great week till then. Bye.